This is Healthcare Now, radio's trending now. Get ready for an exhilarating 30-minute ride through the latest topics driving change in digital health across the news and social media. Join us as our subject matter host takes the lead in uncovering what's hot and what's not. So buckle up and tune in to stay in the know.
This is Trending Now on Healthcare Now Radio. We are where we explore the forefront of healthcare innovations and transformations. I'm your host, Shahid Shah. Welcome to this special episode recording live from HIMSS26 in Las Vegas, where I'm going to be speaking with two guests. First, we're thrilled to have Pooja Babbrah, Executive Vice President, Strategy and Industry, and wait for it, at National Council of Prescription Drug Programs, better known as NCPDP. And I've worked with you guys for a long time, but a lot of people don't even know what the heck that is. And if you know HO7, you know fire and these other things that get a lot of attention, but people don't actually know how important NCPDP is, and the fact that NCPDP probably led one of the very earliest interoperability efforts and proven that electronic interoperability actually is possible. So Pooja, tell us a little bit about yourself and what brings you to HIMSS here.
Yeah, thank you so much for having me. So yes, NCPDP, we are a standards development organization. We've actually been around 49 years now. And as you mentioned, we're the first ones to really do this real-time transactions using standards on the pharmacy side. So the very first standard we created was a telecom standard, which allowed pharmacies to know whether or not they were going to get reimbursed when they dispensed a medication. And that all happened in real time between the pharmacy and the PBM. So pretty proud of what we've accomplished there. My background, I have been in product and strategy for almost 3 decades. So very early days of e-prescribing, even before we had intermediaries. I was a product manager who used to send out Palm Pilots to get doctors to e-prescribe. So had been around the space for a long time, worked with a lot of different health IT companies, did consulting for about 10 years, and now have come into NCPDP to make sure people know who we are. And, you know, there's a lot going on around interoperability. We are trying to make sure that people understand that pharmacists can be part of the care team and they should be sharing and getting data. So that's my role now at NCPDP, is to really work on that strategy and what we call industry alignment.
Yeah, I think it's a fantastic role, and especially because, as everybody says, that nurses need to be upskilled and then act at the top of their license. Doctors need to upskill in AI, act at the top of their license. But there is this gem of pharmacists that are waiting for being able to help, and it seems like they don't often get called on. Why do you think that is? Why do you think they're kind of like left out, even though they do the thing that we can easily kill us is the wrong drug at the wrong time, right. And they're so important in that workflow. Why do you think pharmacists aren't used more?
Yeah, I think that's a great question. To me, I think we've always thought about pharmacists as dispensing medications. I think COVID actually really kind of brought to the forefront that is not just what pharmacists can do. You know, they are clinicians, and they, during COVID, were able to test and then eventually got the approval to treat for COVID as well. What we ran into, though, interestingly enough, is, you know, we're all kind of cheering when the pharmacists got their approvals to be able to write a prescription for Paxlovid when that happened. But the problem was they needed access to the patient's lab information. And that really brought to the forefront that if we are going to use pharmacists as clinicians, have them part of the care team, that they need to have access to the information. I would say, though, I think there's been pockets of areas. We've had collaborative practice agreements with pharmacists and providers for a long time. But what we're really trying to get recognition now is, even in the community pharmacy, you know, this is a resource that is seeing patients on a monthly basis and can do things like close gaps in care, right? Support chronic conditions. And so as we continue to talk about shortages with providers and new models coming out of CMMI, I think they're starting to get this focus on, you know, there is this group, right, of pharmacists that can do these clinical services.
No, it's really good to have you guys here at HIMSS, because on the show floor where we are now, on the floor itself, there's a lot of demos going on, lots of discussions. CMS is here, ASTP is here, everybody's here talking about the biggest, of course, coverage getting standard is fire, which is good.
Yeah.
But there are a lot of things that you guys have been working on. On Monday, you had a good session to talk about what are the new things that are coming out, how you can incorporate pharmacists more into managed care. So tell us a little bit about that session on Monday. Has anything surprising come up since Monday? What you've seen on the show floor? What you think maybe you weren't ready for as you got to HIMSS here?
Yeah, I think the biggest thing, and you know, I'm starting to see more of our members here at HIMSS, which is a good thing. I've had a couple people come up and just say, because of that panel that we had on pharmacy interoperability, people are trying to figure out how to incorporate pharmacists into their thinking, right? Whether it's in the product side or, you know, even health plans saying, you know, we never thought about how the role that pharmacists can play. You know, that panel really did focus on what are some of the barriers today to get pharmacists the clinical data. We have a group that we've been working, the Sequoia Project. We do have a pharmacy interoperability work group where we just released, there's basically 4 use cases to try to educate the market on what are the things that pharmacists can do. So, you know, test to treat, they can close gaps in care. Another great one is when a patient gets discharged from the hospital. You know, why are we not sending the admit, discharge, and transfer notifications to the pharmacist? They should be ready to say, hey, Mrs. Jones, I see her. I know what her, you know, chronic conditions are, or I know what's been happening with her. Now I know she's been in the hospital, she's getting out. You know, they can play a role in that care coordination, that transition. So I think the biggest thing that surprised me is I had someone come up to me yesterday and say, I've heard your name 9 times since that panel to talk about how do we get pharmacists more involved. So I think it's a recognition that people are now starting to kind of, you know, embrace, I would say.
It's a great recognition. And especially you guys cover things like, as a broad umbrella, having pharmacists in managed care in general. And that was good. So just talk a little bit more about what are the major objections that you hear. Is it just, what I would love for you to mainly hear is, we didn't think about it, but now that we've thought about it, let's go do it. Yeah. I can't imagine it's that easy. Yeah. So what's the hard part here? Why isn't the PharmD more integrated? Is it some challenge with competition or something more simple or more difficult than that?
Yeah, I think there's a couple things. One is, you know, obviously there's this thing with providers and pharmacists, right? I think the message that the pharmacy industry always says is we're not going to take a provider's job, right? Like we want to have pharmacists in a position to be able to support the providers. We know that, you know, with a shortage in providers, even in primary care, there's ways for pharmacists to get involved. But I think there has been tension, to be honest with you, in the past around that of like, you know, hey, we don't want pharmacists to take our jobs, right? Especially in the primary care side. I think that's starting to change because of the shortage. I think the rural health transformation money, there were probably 10, 12 states that recognize that we need to have pharmacy at the table. And so once we get this money, especially we're in the rural areas where there may not be providers, right? Pharmacists could fill in for some of those roles. So I think that's been a challenge. I also think, you know, to go back to the standards, right? Fire has been kind of that new shiny object, right? NCPDP has been around for a long time, but everything you see about price transparency and prior authorization, it's always talked about in the terms of what Fire is doing, what the implementation guides are. But I'll tell you, you know, Tom Keene was on stage for the past couple months talking about the new rule that came out from ASTP, HTI-4, which now EHRs have to certify on the NCPDP standards for price transparency. So a doctor can, within workflow, see what the price of that drug is going to be for the patient out of pocket at the pharmacy. And we've also had a real-time prior authorization transaction for the past decade that now EHRs are going to have to certify to. So I think part of it is, you know, just this, again, this recognition of we do have standards, they're within workflow. How do we make sure that we're recognizing that? And I think from another thing from the pharmacy side is getting some of that data to the pharmacist. So they should have the same information of the providers as well.
Oh, it's very, very important. And I mean, you guys are too nice to say it, so I'll be more blunt about it, is that, you know, healthcare and patient care is not a jobs program.
Yeah.
So most of us know that in the cost of healthcare primarily is labor that is being done by the physicians, et cetera. Part of it is facilities. But a giant chunk of cost is drugs.
Yeah.
And so the person in charge of the drugs after prescription for delivery, dispensation, management, et cetera, is the PharmD, as opposed to the MD or the NP, the PA. So you see that you almost hear like APPs, RNs, and MDs. They're kind of like grouped together.
Yeah.
But then the PharmD is kind of like left on the side. I'm like, wait a minute.
Right.
Huge amounts of cost.
Yeah.
Is managing
the
drug
meds.
side.
Yeah.
But
Yeah.
the person who helps you manage the drug side should be left out on the side. I'm like, this is not a jobs program.
Right,
This is
right,
a
yeah.
healthcare program.
Yeah.
So what is it? Is there policy that still is needed, or is it mainly the kind of work you're doing now, which is education? It's super important. Just telling people, and like you said, there's a labor shortage.
Yeah.
Who the heck is worried about jobs being lost? There's not going to be any healthcare jobs being lost in any time soon. So how can we update policy to help?
Yeah, I think the biggest thing is, we really need reimbursement at the federal level. So pharmacists are not recognized as providers under CMS policy. States have gone forward and actually passed legislation. So, but it's state by state. So you have this matrix of pharmacists can do this in this state. They can't do that. They can be reimbursed. There has been obviously some movement at the federal level. I think there's some new legislation, all of that's being proposed, but we still haven't seen anything pass yet. I think there's a huge opportunity with this new CMMI model, the access model, that is essentially focused on, the digital therapeutics. And I think that's a piece where, if we get pharmacists in the loop, and it's all about managing the chronic conditions. So if you've got a device that you're trying to use, if you're managing the chronic conditions, that's the perfect place to test out using a pharmacist and reimbursing them. So I think it's really comes down to the reimbursement. We have the technology in place to exchange data. We have the pipes, we have the standards. Now we just need to get that reimbursement piece. So
what's interesting is that, I'm glad you brought up the access program, because it's actually quite innovative. It's a true innovation in CMMI,
right?
And it can get more people involved. But interestingly enough, if you hear from lawmakers and others to say, well, we have a 500,000 nurse shortage, we have a 1 million doctor shortage, we're supposed to be short in the next 2 or 3 years by 2.5 million. It would just take one senator, one congressman to lead an effort to say, if all we did was recognize the PharmDs, we cut that shortage by 25%.
Right.
Without new training, without new med schools, et cetera.
Yeah.
So it'd be really interesting to see. And obviously, you guys don't handle all the policy stuff at NCPDP or the interoperability,
right?
But the American, the
Pharmacists
Association could certainly do that. I would just love somebody to just go out and talk to their congressman or senator and say, we have a quick and dirty law that we can pass that will reduce our MD and RN shortage. Right?
Yeah.
That's a way to message this.
It is. And what's been interesting and, kind of to be blunt about it, they've been, the pharmacy associations, again, NCPDP doesn't lobby, we educate, but they've been so focused on PBM reform. Now that that's passed, I'm hopeful that we can start to focus on that reimbursement piece. We have a huge fan in Buddy Carter, who is a pharmacist and in the Senate who can, I think there is something called the CAPS legislation that has been introduced. So fingers crossed that gets some traction.
I would love for that to happen. Because I've worked with so many PharmDs in the past, and because I've built the e-prescribing integration systems. To make sure that EHRs can connect and get drug interactions, actually do e-prescribing. So it's so important. It's such a big part of the cost, and it's just weird that why don't people think about it that way? Right. So with that, we are of course out of time. Pooja, thank you so much for taking time out of your busy schedule here at HIMSS and to share your insightful perspectives. We hope you'll come back later, tell us more about what NCPDP is doing, and whether or not we can just get PharmDs to be included in that bundle of degrees that we call clinical care.
Yeah, absolutely. Well, thank you so much for having me, and really enjoyed the conversation.
Great. Welcome back to our live recording at HIMSS26. I'm your host, Shahid Shah. My second guest is Kathryn Wickenhauser, Chief Strategy Officer at DirectTrust. Welcome, Kathryn. Tell us a little bit about yourself and what brings you to HIMSS.
Sure. Thank you so much for having me. So DirectTrust is a nonprofit membership alliance, and we're focused on scaling trust in health technology. So we really focus on that in two ways. The first way is through identity verified secure communication for healthcare. And then the second way is independent accreditation of health technology. So we always love coming to HIMSS and connecting with members in the health tech community and really thinking about what's now and what's next for health technology and our broader community.
Yeah, what I love about your community-oriented philosophy and strategy. And that's what's great about HIMSS is it's very, very community oriented.
It
Lots
is.
of people that you wouldn't be able to see. So what's been your favorite part of HIMSS so far? Anything surprised you? Did you learn something that you're like, I didn't know that?
It's always so refreshing, I think, to come here and to learn what other people are doing and their approaches to different problems, and really to hear where people think things are going, what's next. And so I don't know that there has been anything truly shocking to me, but just thinking about how much AI has changed in the past couple of years and how much that has entered our conversation. For a long time, specifically in the interoperability world, we've been focused on building the pipes and just making sure that the technology was there so that we could have information exchange and data exchange. And now we're at the point where the technology is built, the technology is there. It's more about the education to help clinicians and others, patients know that that's there and how to use it. And also ensure that what we're doing in our own organizations supports that type of information exchange. So thinking about AI and how that layers into and what that unlocks, I've been really pleased to see here at the Interop and Smart experience and the different demonstrations that they do, showing different technologies working together. It really emulates the flow of what we see in real life. And one that caught my attention was a patient actually requesting their records, getting those records, and then connecting it to an AI tool to ask it questions. And knowing that that's really where we're at, and that's where things are going to continue to evolve. So I think I'm very hopeful for the future. There's a lot of work that's been done, and I think we need to give ourselves credit for that. But there's also so much to be done to build that world that we really want. I'm excited about that.
And that's great. I mean, in fact, that's where DirectTrust fits quite nicely. So because there are so many acronyms and terms that are floating around here, you have to know TEFCA and you have to know FHIR. Where does DirectTrust fit in into that larger ecosystem?
Yeah.
And if you're a hospital health system, you're trying to lead the effort of interoperability.
Sure.
Where do you fit so that people can fit you into the right place?
Great question. And I think this is something that's especially important because there's one thought of who DirectTrust is, and then there's actually who we really are. So when we think about interoperability and exchanging information and what we've been focused on for a long time, there are different ways that we can send information, that we can receive information. If we think about our real life and even how we communicate with others, think about that we have multiple ways that we communicate, right? We talk on the phone, we text, we email, we instant message. There's so many different ways that we communicate, and we pick the right tool for what we're trying to do. It's very similar in Interop. So there are different tools and they're complementary. You pick the right tool for your job and what you're trying to do. So if we were to really pull back interoperability to the most basic levels, there's essentially push, where we need to send information to someone who needs that information. And then there's pull, where we're looking for certain information and we request that information in. So we've been focused a lot, the Interop community has been focused a lot on the pull piece and making sure that that works. That's where we hear more about FHIR and kind of the future and what that looks like. TEFCA is really focused on the pull piece, but push right now, the only network at scale for push messaging is the DirectTrust Direct Secure Messaging Network.
But fax is also there.
Fax is also there.
Just kidding.
It's a good point because we do have a consensus body that's looking at layering additional security protocols on top of fax so that fax can be identity verified, can be secure. So it could possibly play in as an interop mechanism in the future. It's really that secure, the identity verified piece that allows us to trust interop. So again, there are multiple ways that we can do that. And I like to think of them as complementary. And ultimately, I like to think of this as a team interop approach, that we're all working towards the same goal. There's just different tools that we use to get there.
And why is it that push is so different in terms of identity and other requirements on security than pull?
I don't know that it's really different from the security pieces. From the very beginning when DirectTrust was founded, so just rewinding the clock a little bit, DirectTrust was the result of a public-private partnership from the Office of the National Coordinator all around how we do this. How do we do push messaging, specifically for referrals, care coordination, things like that, where we do need to send information. And so they were looking at security and identity verification from the very beginning. And so they brought together all of these different stakeholders to figure that out. It was a couple-year project and it was successful, but then ONC knew that they needed to pass off the project. And that's really why DirectTrust was founded, was to become that nonprofit governance and technical trust framework home to be able to do this in the future. So we really were one of the original trust frameworks to make this happen. And it's all built on that technical trust, which includes that identity verification. So we're hearing a lot about different identity verification models. You know, the one right now, IAL2 and AAL2, we hear those acronyms a lot. You mentioned acronyms. Those are coming up a lot, and that's really used to establish trust. But it's identity verifying the individual, the organization, and then cryptographically binding that to their address or their endpoint, whatever methodology that they're using, so that when you're communicating with them, you can know and trust who that is. So it is really next level identity verification and security to ensure that our sensitive information, our health information is really protected as it should be.
Yeah, and that's good to know that we're unifying the idea of pull versus push on the, especially with identity. Where do things like the new individual access services and the identity required to do IAS. And the example you gave, which is perfect, is the consumer themselves doing this.
Right.
So where does DirectTrust fit in those kind of areas?
Sure. So again, multiple different ways that you can do things, right? And there's different tools for different jobs. So IAS is really at this point about, I'm a patient, I'm looking for my information, show me all of my records, and pulling them all into one place. That's really where the conversation is focused right now, especially with TEFCA. Where DirectTrust fits in is we actually allow for patients to have a direct address, an identity verified, secure way that they can communicate with their clinician or whoever else they want to. Some technologies actually implement this into their portals. So it is that extra level of security as patients are communicating with their clinicians. So it's just a different mechanism, right? So if you have information and you need to send it somewhere, you need to push it somewhere, that's where DirectTrust would fit in, and that's where a patient-consumer direct address would fit in, would be able to securely do that and get that information to that clinician in that secure way.
So in the terminology, when we first started with secure messaging, it was just called literally secure email.
Yeah.
But then you had the direct protocol, which was absolutely necessary. And in fact, it seems like it would be a lot easier for patients to just sign up for their direct address, because they're offered pretty widely now. So why do you think there is this tension between patient portals, where you have to pull from it and go to it, versus a direct protocol where you could literally just send messages as needed, just like with secure email? So why that? Does it feel like tension, or am I overstating it?
It's a great question. I mean, I think if we think about it, we still have platforms that we go to engage in email, right? So just using that as a simpler analogy, and we might even have different email addresses, different portals that we go to if we think of our technology platform like a portal. So for instance, I use Gmail, but I also have an Apple account too, right? So those are different items that I need to log into. Now I can pull them into one tool and I can see both of those accounts in one tool, but I think it's similar to what you're describing, that a lot of times when these addresses are issued, especially for patients and consumers, it's tied to that tool. The tool is the one that's supporting it. The great thing about direct secure messaging is that it can be done through an actual software application, or can be embedded in a software application, but it can also be web-based. So I just saw a demonstration upstairs here at HIMSS where someone showed their technology of how it was a web-based access to get into their direct secure messaging inbox and be able to do direct. So again, different tools, but often addresses are tied to that tool.
Yeah, it would seem like DirectTrust probably needs to push the idea of having a Gmail for the direct protocol.
It would be very cool. Yeah.
So CMS recently announced plans for their Medicare app library, and they mentioned, DirectTrust's Care and Code of Conduct accreditation as a pathway for that participation. So talk a little bit about what is the Care and Code of Conduct. Why did it matter that you guys were recognized by CMS for that?
Yeah, great question. So we're really excited about this. Obviously, this is new news and is exciting. So a lot of people know DirectTrust for the direct secure messaging side, but just in going back to our basic roots and where we needed to make direct work, not only was it the technical trust piece, but it was also validating. It was accrediting to ensure that those network operators were meeting the standards that they needed to meet too. And that's really where our accreditation prowess kind of came from. And then in 2023, we merged with ENAC, the Electronic Health Network Accreditation Commission, merged into DirectTrust. And so their accreditation programs came over too. Around that same time, we were working with the Care and Alliance, who's a wonderful partner, on actually validating their Care and Code of Conduct. So the Care and Code of Conduct is a voluntary code that you can sign, and it essentially captures how patients can get access to their data when, where, and how they want to, and sets forth expectations for data privacy, how that data will be used, et cetera. So again, voluntary code, but we worked with the Caring Alliance because they said, hey, you have experience doing these accreditations and actually validating these things. So that's where we came up with this accreditation program where the code of conduct actually became criteria in our accreditation. So basically what CMS is saying now with the Medicare app library is the Caring Code of Conduct is extremely important, and we need a place where consumers can come and know that they're using an app who is doing what it should be with their data and that they can trust. And so the Caring Code of Conduct accreditation from DirectTrust is one of those primary pathways to be listed in that library. So essentially a seal and accreditation from us would validate that, yes, you are doing what you said you needed to do. And so that's really exciting. So we're seeing interest in the program, and we're really looking forward to continuing to partner with the Caring Alliance and CMS to have more trust in apps and health technology.
Great. So just in the last few seconds that we have, if you look across the next 2 or 3 years,
Sure.
Especially because you started off with an AI comment,
Sure.
what now do you see these new technologies allowing you to do with now a new trust layer
Yeah.
that perhaps couldn't be done before?
Yeah.
Is it that mostly that consumer directed part of it that you're excited about? Or do you see still more benefit coming to institution sharing?
Both. I'm really excited to see what happens. I think there's going to be a lot that's unlocked now from AI, but it's going to be rapidly evolving, right? So this is something that we've seen rapidly evolve so far. DirectTrust does have an AI accreditation program for AI that points to NIST risk management framework for AI, but even there, that's rapidly evolving. So I'm really excited to see what happens in the future, but I think giving patients and consumers more control of their data, more access to, and gaining insights from that is something that we all benefit from and we all should continually be striving for.
No, and that's great. So Kathryn, thank you so much for taking time out of your busy schedule here at HIMSS to share your insightful perspectives with us. And patients and institutions, you have ideas. Like if you're getting stuck somewhere and you need help getting over the interoperability hurdle, please definitely reach out to Kathryn and the team. We hope you'll come back later this year and tell us how things are moving along.
I would love to.
DirectTrust.
Thank you.